coming to a doctor every month to beg for a script, it's pathetic. I mean, they hate it. They're stuck though. My name is Cristian Zanartu is my actually Spanish sounding name. They call me Dr. Z here at the clinic. I am, what it is that I do is I'm a palliative care doctor. What palliative care means is that I take away the suffering of advanced and chronic conditions. What percentage of the battling of the opioid epidemic budget is going into actual prevention or rehabilitation? Is less than 5%. Police enforcement is the big bulk of it, which again makes no sense. This idea of like, if kids in high school had, one session a week of body mindfulness, how to care for your posture and your body and your body disposition, how to feel your body, how to care for it, right? The results would be, the cost savings of that intervention alone, right? The idea of like how to significantly help people rehabilitate, not just in state methadone clinics, but actually do trauma rehabilitation, because nobody becomes an addict for fun. These are largely traumatized people that have, had multiple pre-adolescent, very traumatic experiences. Pre-adolescent sexual abuse, particularly in females, early parental abandonment or imprisonment, maternal or parental depression, like your mom being depressed while you were a toddler, has huge implications on how much arsenal of internal resources you're going to have to cope with life. So these people, to think about them like at fault and to make the only way of dealing with them to further police and force them, is so insulting to the experience they've actually had. And then they create this conduct in us physicians where, we're going to police physicians too, stop prescribing that stuff. So we become no-sayers, but no-sayers with no alternative, right? And no-sayers that have no understanding really of what it is that a pain experience is about. We haven't been told, that, there's a huge element of compassion that needs to go into that no. We haven't been taught that. The irony is that, again, 1 of every 3 people that are going to come into your office are going to be complaining of some form of pain. And every single medical student in this country didn't spend more than a day learning about chronic pain. And again, that's where, when we're thinking about alternatives, hopefully inserting alternatives that compared to an opioid are tremendously healthier, like medical marijuana, making them a part of the arsenal shouldn't be the exception. It should be easy to get, because what I've been telling my colleagues, it's the irony, my colleagues who are prescribing 180 tablets of Percocet to their patients, they come to me and they ask me, because I'm the only physician prescribing marijuana in the entire area, they ask me in a whisper, what do I think about adding medical marijuana to this patient? In a whisper, like if they were asking me something obscene. And it's the same physician that just prescribed a lethal dose of narcotics, so it's really backwards. Again, I am not saying, that marijuana is panacea. I'm not saying marijuana is the one-trick solution, but it's definitely a healthier alternative that we should at least consider. And in this regard, I think, lay people, and recreational use are eons ahead medicinal, which is, again, we're missing an opportunity here. You go online, you go to leafy.com and you say, I want a hybrid for migraines. There's a score, and it's something that is really actually a topic right now, which is patient-reported outcomes. We don't need data. If you have tens of thousands of people reporting their results, it's pretty valid if you think about it. If I have 20,000 people suggesting that this particular hybrid of marijuana is great for chronic back pain, great for lack of energy, or they're eons ahead of whatever medicinal is doing, because we've been so restricted, right, by DEA, by keeping the substance as a Scheduled 1, that there's no quality research, So we're going to miss an opportunity.